Hi, my name is Steve Bright. I'm a general practitioner at the Windrush Health Centre in Witney in Oxfordshire. I'd like to talk to you about venous thromboembolism, that's deep venous thrombosis and pulmonary embolus. It's a pretty important problem, especially if you're one of the 60,000 people a year that are estimated to die from clots. Clinical diagnosis is pretty darned inaccurate. Only 15% of people that we think might have a deep venous thrombosis actually turn out to have it. What I'd like to do is to talk about a system that we're planning for our practice-based commissioning group, where if you have a patient that you think has a deep venous thrombosis, and also there's a system for pulmonary embolus, you go through with them a scoring system called the Wells scoring system, and there's one for each of them, one for DVT and one for PE. The one for deep venous thrombosis has 10 aspects to it. You go through it and tally the score. If the score is 1 or less, then that's considered a low probability. And what we then suggest is that you do this near-patient blood testing. If the D-dimer on that near-patient testing is negative for those patients, then you can be reassured that they don't have a clot problem going on. If the Wells score system is 2 or more, then you should be referring them up for imaging. Or if it's a low Wells score but a positive D-dimer, then you send up. It's estimated that for the patients that we'd see, about 40% of them will have a negative D-dimer and a low probability. So that's 40% of patients that you might otherwise have had to send up on that long, arduous journey up to the Churchill Hospital that you don't have to. There's also the same sort of system for pulmonary embolus. This is a 7 aspects to that score. You tally up that score, and if their score is 6 or less for the pulmonary embolus scoring, then you can do the near-patient D-dimer, and if that's negative, you can be reassured that they haven't got a DVT. What we're now going to go on to is how to actually do the blood test.
There are two ways of getting the blood for the test. One is venous, and the other one is from a finger prick, a capillary sample.
Everything's set up, taking the blood in the old-fashioned way, and it can be put into the sodium citrate tube, so the light blue one, or into the EDTA one, sort of the purpley type colour. Get your test with the cartridge, check that it's within date, and that's fine. It's October 2008. Open it up, and if you look at the test, that's it. So the blood and buffer go in there, and this is where you get the test. When you get it out of the kit, some people are a little bit surprised because they think, oh, there's already something there, has the test gone off because there's some yellow bands. That's fine, they're meant to be there. With the venous sample, you use one of these pipettes, which is different from the one for capillary. It's sealed at this end. The idea is you get your blood, so I'll do it from, this is from the sodium citrate. Make sure it's mixed. Make sure it's mixed. You press the tube to squeeze out a little bit of air. Dip it in, release your finger tension, so you're then picking up some blood. Then go into the buffer, just hover above it, and put 1 drop. Then you wait for that to soak into the paper. It only takes about 5-10 seconds. Then your buffer solution, you put 2 drops in, 1, 2, and you wait for 10 minutes, and you read the test at the 10-minute mark. And what you should find, probably after about sort of 30 seconds to a minute, is we should hopefully find a tide mark beginning to work its way up. There it goes, this purple tide mark. And that works its way to the top. So set your watch, clock, whatever, 10 minutes time, you then read it.
The other way of getting your sample is through a finger prick stab and capillary sample. You need to give a good stab and have a good supply of blood. Might be worthwhile warming up the hand a little bit beforehand. Through capillary action you fill this tube up to the black line. Note that the tubes for this are different from the venous one. These are slightly bulbous ones with a black line on. So you fill it up to the black line, and then you then press the bulbous part of the plastic tube to get the drop to fall into the well. Once again you add 2 drops of the buffer solution, get the tide mark come in, and then after 10 minutes you read the test. It's a bit like a pregnancy test, and 2 lines is a positive, which means it's got a raised D dimer, and the implications are that you can't exclude a venous thromboembolus, whereas if you've just got the 1 line, the control, then you have a negative D dimer, which means that you can safely exclude a venous thromboembolus in this patient.
To summarise, if you have a patient that you suspect may have a DVT or a PE, who otherwise you might previously have referred on, if you go through with them the Wells score for their DVT or PE, whichever is applicable, if it's a high score, don't bother doing the test, they still need referring on. If it isn't a high test, then you can do the near patient D dimer testing, and if that's negative, which it probably would be in about 40% of the cases that you'd be checking out on, then if it's negative, you don't need to refer them on. Everybody can be reassured that they do not have a VTE. If it's raised, it doesn't mean that they've got a DVT or a clot, but it means that you can't exclude it, so then they need onward referral.